Oh, sure. Okay, hi everyone, and welcome to the monthly seminars of Big Data Health Science Center at the University of South Carolina. I'm Amir Karami and the social media core director of the center. Today, I'm happy that we host a great researcher and a scholar who focuses on social media, health, and big data. I have read, that the paper of Moons, and found her work, very interesting and useful for different purposes such as research, policy making, application development. Dr. Moon the Chaudhary is an associate professor of the interactive computing at Georgia Tech. She works on developing computational techniques to responsibly and ethically employ social media in understanding and improving mental health using different methods. Such as social computing, machine learning, NLP, or natural language processing. With insight and theories from different fields such as social, health, and behavioral sciences. She received several awards, such as the 2021 ACMW, which is ACM for Women, a Rising Star Award, best paper in different conferences such as Triple AI, and her work was covered in different, that in popular press, such as New York Times, NPR, and BBC. She received, I think, more than $5 million from, funding from different agencies such as NSF, Cisco, Microsoft, CDC, NIH, and YAFA. So again, I'm so excited to have her today, and that if you have any question, please you can put it in the chat box or Q&A, or at the end of her presentation, you can raise your hand using the icon in the Zoom, and use the voice to ask your question directly. So I think we are ready for Dr. Chaudhary, and stage is yours.
Thank you so much, Amir. Let me try to see if I can share my screen.
Sure. I'm going to turn off my video to avoid any, distraction.
All right. I hope my slides are visible.
Yep, they look good.
Okay, wonderful. Well, thank you, everybody, and hello. It's my pleasure and honor to have this chance today to talk to you, and thank you for joining. So my talk, in my talk today, I'm going to be reviewing some of the work that we have been doing at the intersection of social media and mental health over the past several years, what we have seen to have worked in this area so far, what has been successful, and then importantly, what we are still missing. And then I'm going to be discussing a case study that uses synergistic and collaborative approaches to allow us to reflect on some of the things that are missing and how do we go about filling some of the existing gaps. And then I'm going to be concluding with some directions for future research on challenges that still remain unaddressed, but which will be really critical for us to make sure that the potential that we see in employing social media data and mental health are actually realized in the real world. Before I start, I would note a content warning. In my presentation, there will be some descriptions of serious mental illness, self-harm, suicide, and so on. So we all know that, today we are powered in our interactions online by a number of different platforms. Because of our activity on these platforms, we are leaving behind very rich digital traces in the scale of, hundreds of thousands, millions, and billions. And what has happened is over the past decade and a half, we have seen a new field emerge that has benefited from this rich repository of data. And that field is called computational social science. And this field has been making many significant strides into improving our understanding of a variety of different social phenomena. So to just give you some examples of what this kind of data can enable, we now have new ways to measure our social interaction, our moods and emotions, our political ideologies, our collective action, and importantly, and most relevantly to this talk, our health and well-being. So in the initial part of this talk, let me take this opportunity to share with you some of the highlights of the work that my collaborators, my students, and myself, we have been doing since the past few years, showcasing the computational use of social media data for mental health. And then the way I'm going to structure this initial part of our conversation is through the lens of crisis events. So we have been living through many different crises over the last year and a half. We are still living through a pandemic. So the examples that I'm going to be highlighting here will speak to some of these crisis events and the role that social media has provided or played in helping us better understand mental health in these trying times. And then the second way I'm going to be structuring this initial discussion is through the use of the social ecological model, which is a widely adopted conceptual framework in the public health field. All right, so let's start with the individual level. So one thing that we can note about crisis in today's sort of digital age is that they're frequently accompanied by a variety of different misleading information that circulates widely on the internet and these platforms like social media. So while on the one hand, we have crisis, obviously there is a direct impact of the crisis on people's lives, but a considerable number of people are also indirectly affected because they're exposed to these misleading information, or what is known as misinformation. And what could be a better example of that other than the COVID-19 crisis. So in the study that I'm talking about here, we study how exposure to misinformation, as indicated by people's sharing behaviors on social media, it affects their psychological well-being. So to answer that, we conducted a large-scale observational study based on a propensity score matching causal framework. And we analyzed over 80 million Twitter posts made by close to 80,000 Twitter users over the first year and a half of the pandemic. What did we find here? So we found that people who shared COVID-19 misinformation, they actually experienced approximately 2 times additional increases in their anxiety when compared with similar people who did not share COVID-19 misinformation. But what was even more enlightening to us was the socio-demographic differences in this phenomenon. So we found that female Twitter users, racially minoritized groups, and individuals who had lower levels of education, they experienced disproportionately higher increases in their anxiety levels after sharing misinformation compared to people who did not. So what this study tells us is that it opens up an opportunity to gather new kinds of evidence that can be added to the efforts of social media platforms towards moderating or tackling misinformation and its adverse effects at the time of crisis like COVID-19 and others. One of the opportunities from a practical sense that this kind of work can lead to is how do we think about allocating resources to particularly vulnerable individuals who are disproportionately negatively impacted in terms of their mental health due to sharing and exposure to misinformation. All right, so now let us move a degree higher in the social ecological model conceptualization. Let's talk about communities. So in this study, we are talking about a specific type of community, situated communities or college campuses. And the particular kind of crisis we are looking at here are gun violence incidents. So what we did in this work is we leveraged social media data and we proposed computational techniques that can allow us to quantify and examine stress responses that these communities experienced after gun violence incidents happened on these campuses. So we looked at 12 different gun violence campuses here that spanned a period of 5 years. And then we gathered Reddit postings from dedicated communities on the platform that were about these 12 universities. We used an interrupted time series based framework. And what we found is that there were amplified levels of stress following these violent incidents, which is to be expected. But what was interesting is that these amplified levels deviated significantly from the usual stress patterns that you would expect to see in college campuses. In fact, if you were to dig deeper into what some of these amplified levels of stress look like in these cases, we found that there were distinctive temporal and linguistic changes that characterize these situated communities. And these included patterns such as reduced cognition, higher self-preoccupation, and more death-related conversations. So one thing is, I don't need to emphasize so much, is stress is a persistent well-being challenge in college campuses and in college communities, whether or not there is a crisis, right? And it impacts students' personal, social, and academic lives. But when we have these kind of crises, when we have these violent events that happen on these campuses, it not just aggravates student stress, but it also induces feelings such as fear and trauma. So on the one hand, while we know that there are direct impacts of incidents such as these gun violence incidents on students and these communities, but at the same time, we also have to consider the profound negative psychological impact that these incidents leave in the lives of these communities. So what this study allowed us to do is to think about what could interventions look like and policy approaches look like that college campus administrators could think about when these kinds of crisis events happen, so that specific subgroups on campuses could be connected with timely help and care in the aftermath of these crises. And then finally, using the social ecological model, let me give you an example of a study that uses social media to understand population level behaviors. So again, we return to the COVID-19 pandemic. And one thing that I would say is this pandemic has caused many disruptions in the personal and collective lives of people. And mental health has emerged as a significant impact beyond sort of the direct impacts of the crisis. So what this work did for us is it provided population level insights into the various kinds of psychosocial concerns that people experienced in the pandemic. And for this, we leveraged Twitter data again. We had 60 million Twitter streaming posts that were geolocated in the United States over the first 3 months of the pandemic. And we wanted to see in what ways are these psychosocial concerns and expressions different in this time period compared to a time when there was no pandemic. So we collected an equally sized sample of Twitter postings from 2019 in order to understand those shifts. So what did we find? So if you notice these trends on the slide, we found that actually of all the examined psychosocial expressions, they all increased during the COVID-19 crisis. But at the same time, we also observed that there is a steady decline and eventual sort of plateauing in these effects, which you can attribute it to be to habituation or settling into essentially a new normal. When we conducted language analysis, what we found is that there were very unique uses of social media during this pandemic. And that's shown in the chart to your right, where we found that people were expressing these psychosocial and mental health concerns about their personal and professional challenges. They were concerned about precautionary measures, access to healthcare, other pandemic-related awareness, but also they were using these platforms to seek support and engage in candid conversations of mental health. So in one way, you can imagine the social media platforms to have played an important role in destigmatizing and normalizing some of these conversations around mental health. So what this study tells us is that there is a lot of potential that lies in providing insights to mental health stakeholders and policymakers so that they can plan and implement different kinds of measures to mitigate mental health risks that almost is parallel or complementary to the pandemic-related crisis that we have been living through. All right, so just to take a pause and reflect on what we just discussed, you might be wondering, this all sounds very promising. There is clearly a lot of potential for social media, but then what is sort of the next step in this line of work? You might be wondering, are we ready for real world deployment of some of these computational models? And if we haven't done that, what is preventing us from pursuing these directions? And that's what I'm going to be talking to you about next. So I believe that there are two important questions that are yet to be answered before we can take these methods and have them fulfill the promise of different kinds of interventions, such as clinical interventions or public health interventions that can make a positive impact on people's lives. And these two aspects are as follows. The first question is, are the inferences that we are deriving, are they valid? And are they efficacious when it applies to actual people with actual mental health concerns? So to investigate these questions of efficacy and validity, let me go back to the body of work that we have, that has emerged over the past 8 to 10 years, and examine what it means when we talk about the efficacy and validity of social media-based predictive models of mental health. So one foundational thing that we have to observe when we reflect back on that body of work on predictive models of mental health, and that is, in many cases, researchers have operationalized a variety of different online behaviors as proxies of mental health states without actually oftentimes measuring mental health states through a systematic fashion. And there is good reason why that was done. Ground truth data is hard to come by, right? So unlike conventional machine learning tasks where you can have gold standard data in the order of hundreds of thousands or millions by simply asking, let's say, crowd workers to label pictures. In this domain, it's a very sensitive domain, and it needs expertise to evaluate what could be positive or negative examples to train your machine learning models. So ideally, the ground truth needs to come from clinical assessments. But, clinical assessments are difficult to gather, right? And not to mention, there is obviously a lot of challenge and burden to gather that. There's the need for research designs that would not only incorporate ways to accurately measure mental health states, but also incorporate ways to mitigate risk. And essentially, you need deep clinical involvement. So to find a middle ground, as this picture shows, proxies are a good compromise. They are relatively more easily accessible, and they're inexpensively gathered from social media. But also, like, they don't necessarily just rely on lay persons like crowd workers to evaluate something that clearly needs expertise. So researchers have employed a variety of different proxies, and these include things like posting or self-disclosure of a mental illness, following certain mental health accounts, engaging in conversations around mental health, or seeking support on mental health as sort of essentially different diagnostic signals to build machine learning approaches. But what happens due to a reliance on these proxy behaviors, especially from the perspective of efficacy and validity? What impact does that have on practical use of the models that we are building since the past several years? So to answer that question, what we did is we took 3 prominent proxies that have been used in prior work. We have affiliation data, which essentially are people who affiliate or follow or associate with a certain online community or mental health account. We have a proxy which is based on self-reports. These are individuals self-disclosing on social media that they have been diagnosed with a certain mental illness, such as schizophrenia. And then an appraised proxy data set, which is essentially a set of clinicians looking at Twitter postings or other social media postings of a set of individuals and making assessments that this could look like postings from somebody who might be having a mental illness. And then we had matched controls for all of these proxies, which are essentially demographically similar populations where that specific proxy was absent. And then we had patient social media data, which is sort of our way to evaluate the efficacy and validity of the proxy models. And I'll talk more about this data collection in just a bit, but essentially we had a set of social media data that was collected from patient populations as a part of a larger research study. We recruited patients here who've been diagnosed with schizophrenia, and they were seeking treatment at a large health system. And then we also recruited healthy controls, again, based on clinical examination, and the patient population were also clinically examined to have a diagnosis of a schizophrenia spectrum disorder. So methodology here was that of a triangulation. So we triangulated the proxy diagnostic signals by testing the models for internal and external validity. So internal validity would mean training and testing the models on the same type of proxy behavior, and external validity would mean training the model on the proxy behavior and testing it on the patient data. So for simplicity, we used a simple binary classification task. Essentially, we wanted to distinguish the diagnosis of schizophrenia from control populations. All right, so what did we find? So let's talk about the first question first, which is about efficacy. So if you look at these tables, this only reports accuracy measures for brevity. But what we essentially found is, like, if you look at the column on cross-validation, all of these models actually do pretty well. So essentially, the models are giving pretty high internal validity, which helps us replicate some of the findings in prior work, that these are pretty decent models. If we assume a certain proxy behavior to be an indicator of a mental health status, these models do pretty well in predicting that. But now we need to pay attention to this rightmost column on what happens when it comes to external validity, which is when we take these proxy models and test it on patient data. You see across the board that the first 3 rows, all of these models' performances significantly drop when it comes to external validity. So what it is telling us is that these proxy models maybe they are good at predicting the proxy behavior, but when it comes to actually inferring diagnosis in a validated patient population, these models are no longer performing well. But that doesn't seem to be the case for the patient model, which, as you can see, performs consistently well across internal and external validity metrics. I'm telling us that if we really want to have efficacious models, it is a good idea to build those models on patient populations rather than on proxy behaviors. So now, what about the second question around validity? So here we look at a specific validity metric called construct validity, which is the idea that, are you actually measuring what you think you're measuring? So to answer that, we looked at the top performing features in our models for the patient model, which persistently performed well. And then we looked at the best performing and the worst performing proxy model. If you were to just eyeball this table, you would notice that there is just so little overlap with either of the proxy models and the patient model, which tells us that even though the internal validity of the proxy models were pretty good, but actually they may be picking up a completely different set of signals in their data, which is why if you look at the signals that they're using for that detection purpose, that is, these features look totally different from what a patient model would be picking up. So this raises the question of construct validity, which is, are we actually measuring what we think we are measuring? And we are thinking that we are measuring mental health state, but maybe we actually are not doing that. We are simply measuring a proxy behavior, which sometimes could be aligned or reflective of mental health status. Other times it may not be. So what this paper tells us, what this work tells us is that, we have to think deep and hard about the quality of different social media proxy diagnostic signals that we have been using for many years now in predicting diagnosis of mental illness or mental health states. If we really want to translate these models into the real world, and we want them to help people in connecting them with care, or in empowering clinicians to make better treatment decisions, we have to pay attention to these questions of validity and efficacy. There could be many reasons why proxy models are not a good idea. It could be that the kinds of people who engage in a certain kind of proxy behavior are actually not representative of a patient population. We could also have issues of data set shift, which is over time, the kinds of things that people talk about change, and that is sensitive to whether you're talking about patient populations or other populations. Of course, there are questions of representativeness. Not all mental health patients may be actually present on social media, and the people who are present on social media may be using those platforms for different needs, for different purposes, and different ways. All right, so these were the questions and concerns that we need to consider when it comes to the methodological aspects of real-world translation of these models. But there are obviously, you might have thought about, there are other kinds of issues that we need to pay attention to. And a lot of them center around issues of equity and ethics. So, you know, this kind of research raises a number of questions for us, right? There are questions related to agency and power of the people whose data are being analyzed. There are questions of unintended negative consequences that may disproportionately impact, again, the people with mental illness who we set out to help. And then there are questions of ethics. So, you know, how do we consent people? What provisions should be put in place to prevent adverse outcomes or harm resulting from this kind of research? How do we protect a vulnerable population who is subject to this kind of research? And then how do we kind of represent really sensitive life experiences of, you know, real people and real humans in a machine learning framework, you know, which is founded on deriving abstractions from data, and therefore, how do we prevent the risk of dehumanizing people's experiences by reducing their experiences to a series of numbers? And then importantly, what is sort of the social and moral responsibility of people and researchers like us in minimizing the various harms that this kind of work can lead to? And there are lots of other questions that I'm sure are crossing your mind. So essentially, you know, if you want to think about tackling both the methodological and these ethical questions, we have to make these issues a part of the research process itself instead of as an afterthought, right? So in the remainder of this talk, I'm going to be presenting a case study that would allow us to sort of realize the potential of social media and machine learning and mental health, but that would emphasize not only the technical possibilities, but also it will build measures to tackle these issues in the research design itself. So let's dive right in. So this case study that I introduced is an ongoing collaboration that has been going on for the past 5 years between my research team at Georgia Tech and Northwell Health, which is one of the largest health systems in the state of New York, and who do cutting edge research in providing psychiatric treatment to people with mental distress. So our project is called Thrive, and our overarching goal over the past several years has been how do we design and deploy new kinds of clinical tools and interfaces that could be serving the clinicians, the patient themselves, as well as their caregivers, and which are powered by naturalistic data, digital data of patients, such as social media data. So there are many questions, as you can imagine, that we are interested to answer within the Thrive project. The one that I'm going to be talking to you about as a part of this case study today is the question of relapse. So relapse, if we talk about a debilitating mental illness like schizophrenia, it is surprisingly and unfortunately really, really common, even for individuals who are under treatment. So in fact, there are statistics that say that even for people under treatment or patients, up to 80% are likely to have a relapse or significant symptomatic exacerbation in a period of 5 years. Besides being debilitating and significantly reducing the quality of life of patients, what challenges clinicians today about relapse is that it is retrospective in nature. So clinicians' awareness of relapse happens after the relapse has happened for the patient, which is when the patient comes back to reconnect with the health system, and the symptoms are just too severe at that point that they have to be hospitalized. So the clinicians that we talk to as a part of our collaboration who are interested to change this status quo And changing the status quo would mean that can we think about early identification of indicators of relapse that could empower the clinicians better with information that they can use to adapt the treatment or make an intervention in the case of a certain patient at risk of relapse, so that the relapse event or the future hospitalization can be avoided altogether. All right, so as you can imagine, patients are a very important stakeholder in this research because, at the end of the day, it is their data which will power these investigations. And also, they are the ones who are likely to be benefiting or in some cases, if not careful, harmed from the models that we are developing. So we started by conducting a series of surveys and interviews with patients seeking treatment at this medical institution to understand what perspectives they have in this research. And we found that we have overwhelming support for this kind of work because patients recognize the value that volunteering their data in this research could bring to their own health and also the health of their peers. So based on that feedback, we followed a set of best practices in computational psychiatry to our entire data collection process here. We used informed consent from participants. Participants were explained what data is being gathered, how they were planning to be used, and we ensured that the patients had agency to remove themselves from the study at any time without it impacting their treatment at the medical institution in any shape or form. All right, so to answer the particular question of relapse, in this, for the purposes of this case study, I'm going to be reporting on an analysis that spanned a little over 100 patients, about half of whom experienced a relapse in the form of a hospitalization and who were diagnosed with a psychotic disorder like schizophrenia. So let us move forward on how do we go about conceptualizing this prediction framework of relapse. So to talk about some of the modeling considerations that went on as a part of this research, we wanted to ensure that our models, the way that they're built, they reflect the way clinical treatment is provided by the clinicians at this institution, and they reflected the clinical knowledge that exists when it comes to relapse. So one thing that we learned from our clinician collaborators at this point was that relapse events are multifactorial, and in fact, they manifest in many different ways in many different people. So in some ways, it is known that relapse is heavily associated with what is called clinical heterogeneity, meaning that one person's symptoms and experiences do not necessarily match with another person's experiences, even though they both might be experiencing a relapse. The second thing we learned was that there are actually no true positives or true negative examples in this setup because, at any point in time, and any individual has a non-zero likelihood of relapse. So relapse is not an attribute, it's a dynamic phenomenon. But what that means from a machine learning perspective is that the typical supervised machine learning approaches are then not suitable for this modeling task. And the final thing that we learned is that although relapses happen a lot in a lot of patients, but when you look at an individual trajectory of their mental health, relapses are still, a pretty rare event. So somebody could go on for like 10 years without a relapse. Other people can go on for like 2 weeks and a relapse could happen. So to counteract this reality of the data and to make sure that we have enhanced potential use of these models in the real world and at the point of care, we model the relapse prediction problem as an anomaly detection problem, where essentially we have a prospective setting where we are identifying aberrations in a single person's behavior, how those behaviors based on their Facebook data are deviating from the baseline. And then we have periods of health, which are essentially periods when the same individual did not experience a relapse. So in this setting, our goal then becomes to identify those anomalies in a single person's personalized trajectories of Facebook behaviors. So we tried many different anomaly detection models. The one we settled on finally was a one-class support vector machine framework. And let me walk you through what we found. So we found that our model actually does pretty well when it comes to specificity. In this case, specificity meaning relapses that were correctly predicted to be relapses. And we can do that for like 79% of the cases. But where we did not do so well on is the metric of sensitivity, meaning that for about 37% of the cases, our model thought that an instance was a relapse instance for a specific person. But when we looked at the ground truth data, this person was not hospitalized at that point in time, meaning that our ground truth data said that this was not a relapse. So one of the aspects about ensuring that we have a potential clinical value of these models and to avoid the issues of poor efficacy, validity, and also to avoid some of the questions of harm and ethics we discussed earlier, it is incredibly important to not just establish a performance, a positive performance of the models like we have for the specificity metric, but also to understand and unpack where is it that these models are not performing well and why. So to answer that question, we appropriated an yet unused source of data, which comes from the patient's medical records. So a lot of the psychiatrists would note down in an unstructured fashion through a clinical chart review their observations of a patient's symptoms and situation following a psychiatric consultation. So luckily for the 45 false negative cases that we had coming out of our model, for about half of them, we had some data that was available in the patient's medical record in their clinical notes. And then for about 90% of those instances, we found that the clinician actually had recorded the presence of a variety of different psychotic symptoms. But at that point in time, these clinicians did not assess the situation to be dire enough that the person needed a hospitalization. But going back to the way machine learning models abstract context, abstract subjectivities in human decision making, and reduce them into, let's say, binary indicators of relapse or not, that because of that reason, our model learned that these specific instances were not relapse instances. But when we applied that model on the person's data set, Facebook data set, we were probably picking up some of these psychotic symptoms, which is why the model's eventual inference was that this should be a relapse, except that it is not recorded as a relapse because the clinicians did not deem that to be necessary. So this puts us in sort of a gray area where we have models that are deriving inferences about a patient's mental health based on what is being observed in their social media data, but there are inherent subjectivities in the human decision-making process that sometimes may or may not be reflected in the way outcomes are operationalized in machine learning. So some of the biggest takeaways here that we have is that, we can go from sort of thinking about population-based or group-level characteristics and thinking about who is likely to have a mental health diagnosis or not. We can move to a personalized setting where we are essentially looking for aberrations and behaviors in a specific patient's trajectory of their behaviors. And we can use that information to forecast the likelihood of imminent adverse events, in this case, a relapse. So what it tells us is that these personalized approaches can have a lot of potential to inform clinical decision-making, but at the same time, we also have to be careful in how these personalized approaches are actually used and deployed in the real world. We saw some clear disconnects between what the model might be learning from the data and what decisions might a clinician be making about the patient. And then I think it opens up new questions about how do we envision deploying these models and how do we envision some of these conflicts that may arise when the model outcomes and the clinical outcomes do not quite align with each other. All right. So the potential that I talked about of these participatory and stakeholder-centered approaches in essentially building machine learning tools, it's not just limited to the clinical context. I'll briefly highlight an example here, where we have worked with a very different stakeholder and where we have built computational frameworks that are on their way to real-world use. So this, quickly speaking, this is an ongoing collaboration with a federal organization, the CDC. And one thing that I'm sure a lot of you know about is that the rates of suicide in the US population, they have been increasing over the last 20 years. But despite this urgency of these public health problem, unfortunately, there is no real-time information on suicide fatality trends that can be used by organizations like the CDC to drive their prevention efforts. And that's because if you look at national statistics on suicide rates, they are delayed by about 1 to 2 years. So this causes many serious challenges for government agencies to make budgetary decisions, deploy interventions, adapt policies for timely access, and so on. So to address this gap in this collaborative research, we developed a first of its kind machine learning framework to estimate weekly suicide fatalities in the US in near real time. And the unique aspect of this work was that we combined information from your typical big data sources like search trends, diverse social media, with more traditional public health sources, data sources, such as visits to the emergency room, calls placed on the National Suicide Prevention Helpline, and so on. And by combining these diverse complementary data sets, we were able to overcome, some of the biases, some of the idiosyncrasies and unique characteristics that might be attributed to a specific data source. And by focusing on many different streams of data, we are able to also combine the experiences of suicide risk in many different subpopulations who may or may not be represented in one stream, but may be represented in another. So I would note that this work was a very comprehensive study of how we can go about a real-time estimation of suicide mortality rates in the US. And then the models that we developed in this work, they're currently being deployed at the CDC to inform their suicide prevention efforts. All right, so what is sort of the path forward, right? So these are all, they sound like promising solutions and approaches, but I would also say that despite this promise, they're far from being complete. And I do recognize that there are, a lot of unanswered questions that still remain when it comes to this area. So let me walk you through a few of those. The first question that comes is real-world translation, right? How do we think about taking these models and putting them in the real world? We touched on some of these issues throughout the talk today, but I think one thing that we have to realize is that, or rather embrace the fact, is that machine learning models are inherently uncertain, right? We can make a lot of technical advancements. We can have a techno-solutionist approach and keep on tinkering with our models to make better predictions, but we have to embrace the reality that these models are never going to be perfect. Even if a model has 99% accuracy, we are still leaving out that 1%. And if it's a situation like relapse or suicide, even leaving out a single person might have widespread implications on those people. So then the question when it comes to real-world translation becomes, how do we support graceful failure when our data or models actually cannot stand up to the potential use case? Or another way to think about that question could be in terms of the Hippocratic oath that all clinicians and physicians take, which is doing no harm. How can we build our models in a way that do no harm, even when they're deployed in the real world? The other thing about real-world translation we have to keep in mind is that individual interventions, they don't exist in a vacuum, right? They exist as a part of a socially situated and structurally influenced pathway of care. And we found that in our studies with how people appropriate a different technologies such as mental health helplines, and found that what caused people to have poor experiences on those platforms. So as we think about making these machine learning models and social media insights a part of people's pathways of care, we actually also have to take into account the context of the existing pathways that exist for people. Then there are questions of the future of mental health work, right? We are talking of a situation where a new stream of information we are arguing could benefit the clinicians, could empower them with new information. But also we have to ask the question, do these mental health insights or these models that are coming from social media and similar online data, will they be compatible with existing clinical work practices of the clinicians? Will it introduce new kinds of burden to the clinician? Because, we are now saying that apart from all of the work that you're already doing and all of the tools you're using to measure a person's mental health, here is another source of data for you to consider. The question here becomes not just a question of burden, though. We also have to think about things such as how do we balance agency and automation. So like in the relapse case study, we noticed that there could be situations where the model and the clinician don't agree. How do we navigate those situations so that we can have a shared mental model of the patient's mental health between the machine and the clinician rather than have them in adversarial positions? Then there are questions of how these tools or how these machine learning algorithms, if they're introduced in the real world, how they're going to impact the patient-clinician therapeutic alliance and boundaries. So as we think about real-world deployed systems that would function over time, we have to also recognize that sustained relationships, human-human relationships are really important, and the machine learning should take that into account rather than trying to erase or erode those interpersonal relationships. And of course, there are questions of social justice, right? One of the strengths that I feel that, using social media to support mental health of people and inform mental health states of people we have there is that it can allow us to reach populations that are typically not reached when it comes to extending mental health care, because a lot of these people are coming to social media to look for help. So there is definitely an opportunity to close some of the inequities that exist in mental health care through the use of these data and these models. But at the same time, we also have to be careful because we know that many machine learning and artificial intelligence tools are known to exacerbate existing societal inequities. So the way to think about it probably going forward is to think about how can these data and these models serve the marginalized or low resource communities, especially thinking from the perspective of how people's identities, whether it's their race or ethnicity, gender identity, or sexual orientation, how that influences how people understand these systems, and then how do we adapt these machine learning systems in the deployment in a way that people get to trust them rather than feel marginalized or experience further inequities in their search for mental health care. So that's what I have for now. Thank you so much for listening. I would note that this work was possible because of extensive collaborations with my students, other collaborators, and of course the funding organizations without whom none of this will be possible. Thank you for listening, and I believe I have a few minutes for questions.
Thank you very much, Mumun, for your great presentation. I enjoyed, and that now we can go for the questions. So I'm going to start with my question, and then if anyone has a question, they can post it in the chat box or Q&A, or they can raise their hand to ask a question by using the voice. Love your presentation. You cover a lot of things from the social media application, evaluation, and so on. I have some question. I'm going to ask one of them. One of them is that your recent project is related to the CDC that you just showed that that you have a different data set and so on. And one of the data set was, for example, the social media part was Twitter, Google, YouTube, and Reddit, and so on. I would like to know that how do you combine this data set? Why? Because Twitter data is fine because we have a location. But how about, for example, Reddit data? We don't even know that they are in the US or not. How about, for example, Google searching the data? Because you know that Google doesn't provide the raw data, or it doesn't give us the location. I mean that the small location, a small level location, it is just a county or something like this. How do you know that link these data sets that it seems that we don't know even the location of the user for some of these platforms such as Reddit?
Yeah, that's a really good question. So what we did is the work that I just talked about is a national level inference. So we didn't go down to the level of states or counties. That is something actually we are doing right now in a different work. But at the national level, it wasn't as much of a problem. So for Reddit, we had a simple classifier that looked at people's self-reporting, living in the US, and we built a classifier to infer that. For Google, actually, if we looked at Google search trends, and actually that gives you, you can filter, you can go down to the level of states, but not any finer than that. But that was enough for this work. But going forward, yeah, one of the biggest challenges that we have when it comes to combining different data sets is that different social media data sets is that there are many good reasons why you might want to go to the county level or go to even smaller, like the census tract level. And you cannot do that because of missing location information. But I mean, we have done some work in the past. I didn't talk about it here. We looked at Instagram data, public Instagram data, and geolocated Instagrams, and we were pretty successful in gathering information at the census tract level. So we use that information to identify behaviors in food deserts or food insecure parts of the country, and what kind of behaviors and challenges do we find there. So if the research question is to look at finer geographies, you can kind of adopt two different methods. Either go for data sources where there is finer grained location inference possible, or the other way to do that could be to combine it with other non-social media data for which location information might be available.
Okay, great. Thank you so much. You know that now we have some questions in the chat box. The first one is from Sean. Sean is one of our great faculties in, the public health department. She asked us for the relapse prediction study. Are there reasons that you choose Facebook rather than on other social media data, such as Twitter? And then she thanked it.
So that's a good question. And that is something I didn't mention. We actually did collect a variety of different social media as a part of the patient data collection. This specific paper that we did only looked at Facebook, but we have other published work where we have asked questions of relapse and also first episode psychosis around by using Instagram data, Twitter data, and Google search data. So all of those data streams are being collected as a part of this effort. But I think you raise a very good question in terms of how do we keep up with the changing ecosystem of social media platforms, right? And this was a population, this is a study where we are looking at 18 plus individuals. But I do have some other work where I'm looking at teens and adolescents, and we are collecting Instagram data for that population, but obviously a couple of streams that we would like to have, but we don't. That includes Snapchat and TikTok. So yeah, it is a rapidly changing ecosystem, and you kind of have to adapt based on what population you're looking at and what kind of tools are more prevalent in those populations.
Okay, great. Thank you. The next question is from Amit. Amit is again another great faculty. He's the director of the AI Center. So that he asked that in one slide in the two-phase machine learning pipeline, there was deep learning mentioned. Can you provide a little detail on which learning method specifically it was used, I think?
Yeah, so we use convolutional neural networks, and in some of the iterations, we have also used LSTMs. And those are the two that we have seen to work well. We also have found that too many layers during the tuning phase can lead to overfitting. So we had to kind of scale back on using two too deep models. But in general, we have found that the performance gains that we can have with LSTMs or CNNs are far better than what we could have with like simple ensemble techniques. So we tried simpler ensemble techniques where you would, train a model for each data source, and then you use majority voting or another mechanism to combine them. But what we found is that when we use a deep learning to combine those individual predictions, we do a much better job of that. The downside, of course, I would note is like this was a situation where we felt okay to use deep learning models because they're notorious for being so opaque, especially where you are having such diverse data as your inputs to the model. But this was the conversation we had with our domain experts, where we wanted to prioritize on superior performance of the model rather than looking into the model to identify what kind of behaviors or attributes tend to be associated with the outcome. So I believe for the second, if the goal is the second set of questions around finding causal relationships, for instance, then deep learning methods wouldn't be a good choice for that.
Awesome. You know that the next question is from Ehsan. So his question is that about the type of the data in different resources. He asked, is it like always context data, an NLP model, or post or images involved with CNN? It seems that the question is that what types of the data that you analyze is structured, unstructured, and if it is unstructured, is it just focused on the text or including text and images?
Yeah, so that is a question we have approached in different ways and different projects. For the work with CDC, we actually don't use any image data there. We transformed all of the text data into time series signals. And essentially, because it was a time series forecasting problem, we converted all of the data into essentially in a longitudinal fashion and used that. So that helped us harmonize across different streams. But there are other work, especially in our Thrive project, where we did combine image data and text data. So again, I think the approach that has worked for us well is essentially a combination of ensemble methods and deep learning. So we built different models coming from different platforms or different data types together, and then sort of combined them in a sort of second phase to come up with the eventual inference. But I think there are many different ways to approach that. We can think about deriving composite features that combines, image and text data together. And I think there's a lot of opportunity to explore what type of feature representations are the most effective in these prediction tasks when you have such diverse data.
Mm-hmm. So, that I'm going to, thanks again. That I'm going to another question. It seems that there are people, they post a question on Q&A and chat box. I just, that follow it based on the time that they posted. So I'm going to ask a question from Cassidy Bradley, that she, I think she asked that you mentioned that certain socio-demographics experience higher anxiety. How did you determine these demographics from the tweet?
Yeah, so there is a bit of a caveat there, I would note. So for Twitter, people can choose to self-report their demographies, but there isn't a set field to do that. So for that work, we look to inferring demographic attributes, which is established line of work. If you look at the NLP literature, so how do we use signals from social media profiles and language to make inferences about demographic attributes? The caveat I would note is that there are many problems with that approach. I mean, many people would consider inference of demographic attributes automatically to be ethically problematic. I'm totally cognizant of that. And more importantly, I think one of the limitations of these inference approaches is the fact that you don't get at the underrepresented categories. So like, for instance, most gender inference relies on looking at the first names on Twitter profiles, which obviously is problematic because, it doesn't capture people with diverse gender identities, and it disproportionately leaves out the LGBTQIA populations. So, so that said, I think the goal of that work was to just highlight some of the, if we look at the majority categories of different demographic attributes, what kind of differences do we systematically see? But I do agree with you, and I acknowledge that there's a lot of work to be done, maybe in a different setting where we are able to gather people's self-described gender, sexual identities, race, ethnicity, and so on, that can give us richer insights.
Okay, great. We are going to end this session at 12:10, so I try to ask as many questions as we can from different people. So the next question is from Miao Lee. So I'm going to ask just one of these questions because I think she asked two questions. And one of her questions is, how do you ask respondents for their consent to share social media data?
How do I ask?
That it seems that in your study, ask the patient and so on to, that to share their data. It seems that the question is, how did you ask them to share the data? How was your approach to reach them?
Yeah, so this was something that was led by our clinical collaborators, because these are mental health patients, and I strongly believe that we have the right kind of risk mitigation approaches in place that, as computer scientists, we may not be the best equipped to do that. So we relied heavily on the expertise of our clinical collaborators at Northwell. So essentially what happened is there was a dedicated clinical psychologist trainee, a study coordinator, who was not involved in providing treatment. So we wanted to keep the treatment separate from the study, because otherwise some people might feel that there is a conflict of interest, that if I don't participate in the study, I'm not going to get treatment. So we wanted to ensure that that was not the case. So this is a dedicated study coordinator. She had training in clinical psychology, and she's a licensed clinical psychologist. So initially, any patient who came to the health system for treatment, they were approached, they were explained the study, they were provided an opportunity to ask questions, and then there was an informed consent document that they could sign. So it had many parts. We gathered self-reported data on a variety of different validated psychiatric scales, but we also asked them to download their various social media and online data archives. So we actually had a Facebook app until Cambridge Analytica happened. So I guess a lot of people in this call know what I'm talking about. So that definitely messed up some of our social media data collection. But right now, thanks to GDPR, people can still download their archives of social media and other data. And that's what they're doing. So we approached them to request a download of their archives. And then once that was available, the patients could upload those archives onto a secure HIPAA compliant server. And then we also got their consent to access their medical records, which are anyways collected at this health system. So yeah, it was actually a non-trivial amount of work that we had to go through to collect this data, simply because of the vulnerabilities and the sensitivities of the population and the context.
Good. Oh, thank you so much. The next question is from Dennis Davis. The question is, are your data models predictive or intended to raise awareness and flag critical situations? Are the social posts treated as streaming data?
Yeah, so we have conceptualized the potential use case in many different ways. And I would say that there isn't like one answer set in stone on how these models could be used. So we have definitely envisioned situations where the data is coming in a streaming fashion. And if there is some risk that is detected by the model, you could surface a notification to the person. But that can be creepy. That is a use case that I think has many ethically very thorny, and there are a lot of dimensions to be explored there. The use case that we envision probably is more practical and useful in the near term are using these models in a clinical setting. And that could mean that a patient comes in, they give access to their social media and other feeds, allow the clinicians to derive various kinds of quantified signals from those data. And we have been working on building some interfaces that would show summaries of those information about a patient to the clinician, obviously after the patient's consent. And then those data could then be a part of the conversations that happen between the clinician and the patient, or it could be something that is attached to the patient's medical record as sort of a summary that gets updated every once in a while, so that it is a source of additional signal to accessible to the clinician.
Thank you. George Tam, that he asked that, that he mentioned that what an amazing talk. I'm curious about internal vs external validity tests on social media data. I'm wondering if persons who expose their mental health status would be the different population than patients, individuals with psychosis, would talk about their issues when they have sufficient support. So this may explain why the external validity is relatively weak. So I think the question, if I want to repeat it again, is if someone who exposed their mental health status would be the different population than patients.
Yeah, actually, that is one of the sort of post hoc explanations that we had from that work is sort of these population-based differences, right? So the people who choose to talk about their mental health or use the proxy signal to describe their mental health behavior may not necessarily be representative of a patient population. But that is a very important consideration because oftentimes we assume that by looking at social media data alone, we can make a good assessment about the clinical mental health status of a person. And what that work tells us is that actually that may not be the case. So there are a couple of ways forward when that is the case. And that is, we can start with patient populations for whom we have validated clinical assessments so that we don't have to experience this issue of non-overlapping representation. And the second thing we can do is that not rely on a single social media data source, combine it with other kinds of data that might have more reliable clinical signals or clinical information about the patient, so about the individual. So I think the lesson learned here is that there are problems to relying on proxy behaviors that especially harness one single source of data, and we need to do better than that.
That was the last question. I just want to follow up on this question as the last one. Suppose that you collected data from social media data and you have some data from CDC and so on. And if you see that there is a correlation between the data, for example, social media data such as Twitter at the county level and in external data set, I mean that the surveys, if there is a correlation between these two ones, suppose that the positive correlation, does this mean that social media data is representative, or does this mean that we can use the social media data? I mean that, okay, at the local level, I just want to see that. What do you think about this one? I just follow up on that question.
Yeah, I want to say that may give more confidence about the quality of social media data, but we have to be very, very careful there. And that's because it's totally possible that for some confounding factor or latent factor, we are seeing the correlation. That's the, like, it comes down to the question of correlation, and does that indicate, in some ways causation? Because when we talk about representativeness, we cannot, avoid the question of causation. So I think, yeah, it needs more work to figure out if we see a positive correlation, does it mean that social media data is good enough? I would say that caution never hurt people. I think it's probably better than other kinds of survey data, but it is probably not as good as some of the other indicators. So yeah, we need to learn more about these different data sources, their strengths and weaknesses, before we can answer that question.
Okay, great. Okay, thank you so much. That we don't have that more time. So if you have any question, I think you can shoot an email to Moon. And again, thanks everyone to participate in this talk, and thanks to our great speaker. And hope to see you everyone in the next monthly seminar of the Big Data Health Science Center. Thank you so much, Moon.
Thank you so much, Amir and Miranda, and thank you everybody for joining and sticking around. I appreciate that. Hopefully we'll get to see each other in person sometime in the near future. Take care.
Good. Take care. Have a good one, everyone.